بسم الله الرحمن الرحيم. بشكر البرونكولوجي على دعوتي النهارده في السيشن المهمه جدا اللونج ترانسبلانتيشن، واتمنى لهم مزيد من التقدم دايما. نبدا الاول. استاذ دكتور ياسر مصطفى هيقول لنا ethical paradigms and Egyptian challenges in lung transplantation.
مش خلاص. لا خلاص. بسم الله الرحمن الرحيم. Thank you, Mr. Chairman. My subject in this very important session about lung transplantation will be ethical paradigms and Egyptian challenges in lung transplantation. Definitely, ethical paradigms and Egyptian challenges may need more than 30 minutes, maybe up to 1 hour to discuss it. But I will try to highlight some important points. As all of us know that ethical paradigms depend on culture and or religion, and it may differ from society to another society. My agenda today will cover introduction. What about informed consent, resource allocation, community perspectives, donor issues, recipient issues, and the Egyptian challenges which we faced during the start of our project and up till now. As we know, lung transplantation is a sort of allograft, transplanted organ or tissue from a genetically non-identical member of the same species. Most human tissues and organ transplant are of this type, and we have two approaches: living donor or cadaveric donor. We sometimes ask ourselves some questions when we go to these ethical aspects. Is the human body a commodity? This is very important because when organ transplantation start to be practically, there was a market for organs in many countries, especially developing countries, and usually the local laws and regulations should be very strict in order to avoid this. How should decisions be made about who receives scarce organs? Who should pay for transplants? This is very important. Usually the charities and the authorizations and the government should cover this to avoid the market, as I mentioned. Should one person receive several organs or several persons receive one? Should one person have a second transplant when the first one fails, or should a different person be given a first chance at a new organ? Should organs be donated to those persons who have abused their bodies by drinking and smoking, or only to those whose organs are damaged by disease? This is a very important questions, and sometimes we don't face answers easily. So some guidelines: the functional integrity of the donor as a human person should not be impaired, even though anatomical integrity may suffer. The risk taken by the donor as an act of charity is proportionate to the good resulting for the recipient. And the donor's consent is free and informed, and the recipients for the scarce organs are selected justly. The informed consent, which is the first point, is very important. We should depend on the proper diagnosis, the nature and the purpose of treatment, the risk and benefits of such operation, the alternatives. If I don't, usually the patient asks me, if I don't do this transplantation, what are the alternatives? So we have to tell him frankly what are the risks and benefits of not having this option of treatment. The process of obtaining consent also varies tremendously around the globe. Some countries have a presumed consent clause whereby consent to donate organs after death is assumed unless in life the individual had given written directions regarding their opposition to donate. This is a very important regulation, and our countries don't apply up to now the cadaveric transplantation. What about resource allocation? Those who are dangerously wounded must be tended first, entirely without regard to rank or distinction. Those less severely injured must wait until the gravely wounded have been operated upon and rest. This is told by Hens in 1975, and this may be a rule when we choose which patient should be first. Ethical standards dictate that each potential recipient should have an equal right to receive a transplant and to an optimum outcome when donation rates do not meet clinical demand. So hence lung allocation score, LAS, was put for this reason. We have to have a lung allocation score in order to regulate this issue. What about community perspective? How does the broad community view the ethics of lung transplantations? We know, especially in our communities, when the media interfere in something like this, sometimes there is arouse in some areas that people can catch some children in order to take off their organs, transplanted, something like it's very bad and may lead to disruption in the community in such case. What is appropriate tool to gauge public opinion? Is it the media, such as the written word or the electronic versions? If so, both the public and the press show little insight or in-depth understanding of the issues involved. What about the donor issues? The key question is whether organ donation or the process of obtaining consent is ethical. In most countries, legislative requirements mandate that there should be an arm's length arrangement between the team acquiring consent for organ donation and retrieval and the team who will be caring for the recipient. What about the recipient issues? It goes without saying that care provision should be independent of status in the community, wealth, race, color of skin, creed, occupation, or level of education. Where there are differences in outcome between ethnic groups, they seem to be related to differences in propensity for the rejection and racially determined risk factors for cardiovascular disease. So this issue should be concerned by a team and by a committee. It is unethical for lung transplant patients not to take their immunosuppressive medications. I think after all this and after all these expenses and all this effort done to transplant such an organ to patient, he is not his right to stop immunosuppressive medication. It is unethical for them to smoke or to drink after they receive this lung. All these points should be covered and should be discussed and should be regulated in a very proper way. What exactly is the ethical contract when you have received organs that have saved your life when someone else missed out and perhaps died as a result? You have to care about this. Now, what about the Egyptian challenges in lung transplantation? We started definitely and in a very good scientific and professional way in 2018. with my colleagues from cardiovascular, cardiothoracic department, and under the supervision and the encouragement of our dean at that time, Professor Mahmoud al-Miteni. He is now the head of the university. And we started to make a team, pulmonologists. I had a very good colleagues in such team, Professor Ashraf Matkour, Professor Khalid, Professor Iman Hassan, Professor Nihad, Professor Mariam, Professor Haytham, and young staff, Yahya ومحمد فتحي. Definitely, we shared with our colleagues from other departments. We had a committee and consisted of other branches, clinical pharmacy, nurses, radiologists, pathologists, and we start to put the protocol and we start to communicate with very big centers outside, and eventually we had a collaboration with one of the very big centers who is caring about the transplant from a living donor that we have to have in our country, which is the University of Kyoto. And we also, our colleagues from King Faisal Hospital, they had a good experience, but in cadaveric. But for us as a pulmonologist, it will not differ much. It may be the difference between cadaveric and living donor, some technical approaches in surgery, but for us as a pulmonologist, it will not differ much. So we also had another arm of collaboration between our university and the King Faisal hospitals. Definitely in Egypt, we have many challenges. Within the last 2 years, we started our project in Ain Shams University hospitals with collaboration of Kyoto University and King Faisal hospitals, as I mentioned. And 2 years ago, under the patronage of our society, also Egyptian Scientific Society, we make the first cadaveric lung transplant workshop with our colleagues from King Faisal Hospitals, Dr. Mohammed Hussein, Dr. Ahmed Mustafa in Ain Shams with us, Dr. Mohammed Hussein from King Faisal, and Dr. Kattan from King Faisal. And this is some pictures from this workshop. We see here the dean of the college, of the faculty at that time, Dr. Miteni, and Professor Muhammad Awad Tajuddin with us. Dr. Tariq Safat was with us also. And we had lectures at that time and hands-on 2 sessions, session for the pulmonologist, how to deal with patients of transplant after and during, and what are the requirements and what is the role of the pulmonologist during this. And also we had a workshop on living bodies by our colleague from the thoracic department. It was a very good workshop, and it was very successful at that time. Then we start the second step, which is to go there. We had a team went to Japan, Kyoto University, and they were trained. The team consists of thoracic surgeons, ICU, anesthesia, pulmonologist, Dr. Haytham Sami from our department, pathologist, and radiologist. And we have also another team went to King Faisal hospitals. The 2 arms start together, and there was supposed to be a second wave for this collaboration, but sorry for COVID, we stopped this. After the first wave come back to Cairo, we start OPD lung transplantation clinic in our Ain Shams University Specialized Hospital in 2019. And we had many challenges, definitely, when we practice this actually. If we go to the Egyptian law for organ transplantation, it permits up till now only living donor transplantation and is still under discussion for approval for cardiac organ transplantation, although it is present in the Chapter 3, Article 14, the law authorized cadaveric organ transplantation, but with temporary deactivation. I don't know why up till now. They may be fear from the market for organ selling, and it will be a very bad market, definitely. So it needs more and more regulation, but I think it is not wise to deactivate such article, and we need to apply this article because cadaveric transplant is very, very easier technically and practically than living donor transplant. As you know, for living donor transplant, we need 2 donors with same ABO group and tissue matching. That's why when we apply this in our clinic, we find that it is very difficult to get 2 donors for 1 person with compatibility like this. It is present, but our colleagues from Japan, the law there permits only living donors. So they do it. But when we face it in our country for cultural reasons, maybe it was difficult. The expenses of the operation is another issue, but we can overcome this by the charity authorizations, and we already regulate this in the first few cases which are going to do. The expenses will be not by their own. We need to gain experience not only in surgical techniques but also in post-operative follow-up. And that's why we send our colleagues from the pulmonology and other departments to such centers, pioneer centers, in order to get this experience. And definitely when we face, like we did before in kidney transplantation and liver transplantation, at the first we have some problems and then we gain experience very rapidly. The last challenge was COVID-19. Definitely COVID-19, when came, we obliged to stop our project and to stop the cooperation and the travel of the second wave. And we had a promise from the team of the Japanese team to come to our country in last June to have the first case lung transplantation, and we are preparing for that. But all this postponed. Inshallah, we can do it very near. ومن أحياها فكأنما أحيا الناس جميعا. This is a verse in our Quran, Surah Al-Ma'idah, Surah 32. And whoever saves a life, it would be as though he saved the lives of all humans. صدق الله العظيم. Thank you very much.
Thank you, Professor Dr. Yasser, for this nice, fruitful presentation. And first of all, good morning, everybody, my dear professors and colleagues. And I'm very grateful for this nice invitation. The second talk will be presented by Dr. Ahmed Mustafa, Professor of Cardiothoracic Surgery. The talk will be about Ain Shams University experience in Japan. Dr. Ahmed.
Bismillah ar-Rahman ar-Rahim. Thank you for allowing this opportunity to be with you today. I would like to highlight the Ain Shams University experience in Kyoto, Japan. We had 2 waves who had gone to Kyoto, Japan, June, August 2019, and Jan, Feb 2020. So quickly, Ain Shams University hospitals serve a huge number of patients. Being 3 hospitals, they collectively have 4,000 beds. It's now experiencing a lot of upgrades and reforms, modernizing services and adding subspecialties. Regarding the thoracic surgery department in Ain Shams University, all of the surgeons had initial training abroad, European experience. It's an established adult and pediatric referral center for complex airway, redo, oncology, trauma, and vet surgery. It's a valuable transplant experience in King Faisal's Hospital and HAJP France. we had a very good experience in the living donor liver transplantation. We started with Kyoto University maybe 20 years ago. And now we have the services running with 5 centers or more, with built-in anesthesia and ICU teams in each center, caring for more than 1,200 patients in the last 16 years. So why transplantation now? It is now a worldwide acceptable surgical solution for end-stage respiratory diseases. Also, we have to admit that a nation who had built the pyramids, which are actually tombs, and used mummification in the past to preserve the dead, accordingly now is slightly resisting the current idea of cadaveric organ donation. Fundamentals of living donor lung transplantation are getting classically 2 donors, the right lower lobe from one donor, the left lower lobe from another donor, doing bilateral nominectomies, then sequentially reimplanting the lobes. The living donor lobe lung transplantation literature regularly came out from Japan due to the prolonged waiting time for the cadaveric lung transplantation. Encouraging results showed that bilateral living donor lobar lung transplant provides equal or better survival than conventional cadaveric lung transplant, and this is cited by Professor Hiroshi Date back in 2015. That article won the Bronton Prize of the 2014 European Society of Thoracic Surgery. As mentioned before, there are many challenges. The analysis of the United Network of Organ Sharing Database reveals that the failure rate of new programs exceeds 40%. And so we have mandatory objectives. The program must be sustainable. We must have definitive quality measures, and we must carefully plan for the institutional proficiency, for the medical personnel, nursing, supporting staff, financial and administrative. However, starting a new complex program of lung transplant is not an easy task. So after numerous meetings with the Dean, and Shams University President, officials at the Ministry of Higher Education, Egyptian Consulate in Tokyo, the Japanese experience had to be closely studied. Professor Hiroshi Date, the pioneering figure of living donor lung transplant, was contacted, and he kindly accepted to host a team composed of different specialties at his department in Kyoto. Meanwhile, there were some other colleagues who were dispatched to the Kingdom of Saudi Arabia, United States, China, Italy, for the same purposes. Well, the fun part would start, the quick facts about Japan, which we have never visited before. It's by far, it's very far. It's 12 hours direct flight between Cairo and Tokyo. It's the land of the vending machines. There are temples all over Kyoto. It has more than 1,600 temples. We had a complex ordeal of sorting garbage. We had faced many difficulties due to the lack of trash bins. It has the most convenient toilets, and the taxi doors pop up automatically so that we don't panic. The Shinkansen covers the area from Tokyo to Kyoto, around 513 kilometers in just 2 hours and 20 minutes. We visited Japan in summer, so we had experienced the summer sudden torrential rain. It was very difficult to find cheese. We used futons, which are the traditional Japanese beds. And we had some difficulty in eating due to the chopsticks. And it was very great to find all sorts of Kit Kats there. And of course, the excellent etiquette of bowing. So we had an everyday routine there. At 7 a.m., we had to rush to the hospital to catch the bronchoscopy done to the transplant patients, mingling with our Japanese colleagues to know the patient's finest details. What has gone during the night. 7:30, professional, that is transplant round. Around 8, attending one of the numerous multidisciplinary meetings. 9 a.m., we had a quick breakfast from the Lawson at the same hospital. 9:30, we dispersed according to the specialty. Surgeons and anesthesia to the OR, pulmonologists to the chest department, intensivists to the ICU. 2 p.m., 3 p.m., we regrouped for lunch, and we started to work on the transplant manual to understand the videos, to watch the videos. Then at 5:30 p.m., we had to attend the evening transplant ICU round. 18 p.m., regrouping for open scientific discussion and comments, and then leaving at 9 p.m. at the hospital for supper. We had really an excellent and convenient workspace with beautiful scenery, high-speed internet, even a comfortable sofa and a small kitchenette. Most of the meetings were instantly translated to English. Access to the lung transplant video library was granted. Access to the all transplant activities, such as the research, publications, bronchoscopic interventions, intraoperative attendance. The resume transplant meetings were in English. We even revised the transplant morbidities, which were in Kyoto. We were involved in frequent MDMs, the daily twice meeting of the whole department, the pre and post-transplant meetings, the joint thoracic surgery and oncology meetings, the chest department, radiology and pathology meetings, and the inpatient morning rounds. Also, we had access to the daily progress of the transplanted patients at the ICU. Our colleague in the radiology had a full acquaintance with the 3D reconstruction software. It's now installed in our hospital here in Ain Shams. Anesthesia protocol, including the ECMO protocol and preoperative evaluation. Regarding the anesthesia, they managed to get to know the intraoperative advanced monitoring, the ICU protocol, the immunosuppression protocol, and determining the requirements, drugs, and equipments, and other disposables. Our pulmonologists attended daily activities at the pulmonology department at the OPC, the list of fiber optic bronchoscopies, meetings and conferences of the chest department in Kyoto Hospital, University Hospital, the recognition of the medical registry of the patients with respiratory disorders, especially potential patients for transplant, obtaining the respiratory transplant protocol, with discussing it with the Japanese pulmonologists with point-to-point clarification, viewing and discussing the Kyoto Hospital guidelines concerning different other respiratory diseases. And for me, I was in the first wave, and for my colleagues who were in the second wave, we were introduced to the eligibility for lung transplant, the general inclusion criteria and the contraindications, the donor criteria, the recipient criteria, the size matching, the functional and anatomical size matching, the waiting list management. And here, for example, maybe this is not very clear, in this diagram we can find the individual lobar volumes by the software, by the 3D reconstruction software. We had acquaintance with the surgical techniques. We had to get to know how to perform a safe donor lobectomy in case of living donor lobar lung transplant with all its tricks, sequence of events and close coordination, the choice of operation, whether it's single, whether it's double lung transplant, whether it's a living donor or even a hybrid. The choice of incision, whether it's a thoracotomy or clamshell, the use of a perioperative extracorporeal support, whether it's ECMO or the pump, the sequence of the anastomosis, and the management of the bronchial and vascular size mismatches. We had to know the different strategies for management of size mismatch, living donor lung transplant. We have seen the oversized grafts, the undersized grafts, and it's shown here. We had a single lobar transplantation sometimes. We had a delayed chest closure. We had a native upper loop sparing living donor lung transplant in undersized graft, or in right-left inverted living donor lung transplant also in an undersized graft. All these diagrams are from the Professor Hiroshi Deti living related lung transplant, which was published in the Journal of Thoracic Diseases 2017. Well, we had general benefits of our experience in Kyoto. Founding one project at a time, concentrating on the objectives and fulfilling the goals. The importance of extensive medical registration and going paperless digitalization. The significance of the scientific research, which at times comes before the actual surgical training. The importance of the supporting staff, their proper training and dedication, the auditing the results, connecting the literature with the real life scenarios, and developing social networks and close informal connections with our Japanese colleagues. And some specific benefits for our future project, I hope. Now we all talk the same language. We communicate with the same terms. We know that the rejection is diagnosed medically, not histopathologically. We know that the early tracheostomy is beneficial. We know how important is the early rehabilitation. We established and updated a reference protocol personnel adhere to in most of the classic cases. The importance of the regular meetings, exchanging opinions, listening to advices to others, a specific job prescription to everyone in the team, and teamwork and collaboration in a strong administrative system can ensure a project's success. Best experiences and amusing nightmares. Well, we had the cicada. It's possibly wickeder than the summer muggy humidity. It was summer, and the blazing heat for her deafening screaming. And unfortunately, we missed the last train to Kyoto, and we spent the whole night in Tokyo Station, but it was fun. For me, the all-in-one electronics giant retail, the Yodobashi, was great. And the Japanese are by far the politest people on Earth in the neighboring planets and galaxies. And lastly, I would like to address Professor Hiroshi Date. We really appreciate your support in this endeavor. You have been extremely supportive, and I want to acknowledge the extra effort carried by our Japanese colleagues at your department. Thank you for sharing your knowledge and experience with us, and we cannot wait to welcome you in Cairo soon. Arigatou gozaimasu. Thank you.
Thank you, Dr. Professor Ahmed Mustafa, for this very important to-the-point presentation. We are going to listen to Professor Muhammad Hussein. going to talk about comparison between living donor and cadaveric lung transplantation.
Bismillahirrahmanirrahim. First, I'd like to thank the organizing committee and the CHEST from Egyptian Society of Bronchology and the CHEST department for the invitation to talk in this very important session. Actually, it's a very important topic to compare between the living donor and cadaveric lung transplantation. Dr. Yasser had a very nice presentation about the ethics of lung transplantation and is it ethical to start a living donor lung transplantation while there is another way of doing cadaveric without exposing two healthy donors for the lobectomies or not. On one hand, we have the cadaveric lung transplant program where we take the lungs from a cadaver, so there is no two donors, and we give the patient finally 5 lobes. But most of these donors are prolongedly on the ventilator, so sometimes they are infected, and there is higher ischemia time, of course, of the graft. On the other hand, for the living donor, you give the patient small but perfect grafts, but at the same time, you are exposing the two healthy donors for lobectomy, which can be safe in good surgical hands. And the third thing that you are giving the patient 2 lobes only instead of 5 lobes. So let's go through the presentation to see is it wise to do a living donor lung transplantation to start our program or not. So again, always I start my presentation with this question. Is it possible to start an Egyptian lung transplant project? I think it's possible, and that's why we are here. Which is the optimal way to start living donor or deceased donor? We will talk about that later. So is it possible? This is the answer, actually, that other countries with the same culture and maybe we have also better health personnel and in surgery and in medical and in different subspecialties. They started long time ago. So that was in 2016 in the International Society of Heart and Lung Transplant in San Diego. And in this meeting, I had the presentation about 100 cases of lung transplant in Saudi Arabia. And in this meeting, I don't know if Dr. Hiroshi Date remember or not, we had a chat, me and him, about the possibility of doing a lung transplant program in Egypt. So 100 cases in Saudi Arabia in 2016, and in December 2020, we had done a total of 224 lung transplant in Saudi Arabia. Iran started since 2000, and that was their article about their experience of about 8 years experience in lung transplant, and they had done 24 lung transplant procedure. That was published in 2008. And finally, we have already the law to organize lung transplants from cadavers, the law of 2010, which gives in the number 14 law, لا يجوز, I'll tell it in Arabic, لا يجوز نقل أي عضو أو جزء من عضو أو نسيج من جسد ميت إلا بعد ثبوت الموت ثبوتا يقينيا تستحيل بعده عودته للحياة. ده البرين ديد دونر. اوكي، وده القانون دوت اقر في 2010. وطبعا لازم يكون في اجماع اراء من لجنه ثلاثيه من الاطباء المتخصصين في امراض او جراحه المخ والاعصاب. فبالتالي اللو موجود. الفتوى الدينيه موجوده من الازهر since 1990s. الفتوى الدينيه موجوده من هيئه كبار العلماء في السعوديه. الفتوى الدينيه موجوده من الشيعه في ايران. فبالتالي دي مش اوبستكل عندنا. فدي الماده رقم 14. I'll go rapidly through historical note about lung transplant, which started in 1963, first human left single lung transplant in Stanford in USA. But it was just a start, and the patient lived only for 18 days. The first midterm success was in Belgium, 1968, where a patient in Gent in Belgium had done a single lung transplant again, and the patient survived for 10 months. The first real successful heart-lung transplant was done in 1981 in Stanford University in USA for a patient with idiopathic pulmonary hypertension. The first long-term success for a double lung transplant in Toronto, 1983. And since then, more than 50,000 lung transplants were done all over the world. And now the lung transplant is considered a standard of care for end-stage respiratory disease. Coming back to the living donor lung transplantation, it started in 1993 in the University of Southern California in USA. That was started in response to the mismatch between the supply of organs from cadavers and the demand for lung transplantation. So the supply is much lesser than the demand, and that's why they started living donor lung transplant. But in the beginning, in the 2005, 2004, 2005, they nearly stopped the program after the introduction of lung allocation score, which gave the lungs not for first come, first serve, but for risk and benefit of the potential recipients. So now they rarely need to do living donor lung transplant there. Although this living donor lung transplant technique was performed in USA for the past maybe 15 years, almost all the reports about living donor lung transplant is coming from Japan centers, Okayama and Kyoto mainly. And currently the group in Kyoto, led by Professor Date, is continuing to pioneer this technique, and we are very happy in Ain Shams University to learn from them. So when I started to write this presentation to do the comparison between cadaveric and living donor lung transplant, so living donor now is mainly done in Japan. So how to do the comparison? So I decided to do the comparison between the living donor in Japan and cadaveric donor in Japan, also in the same centers, because they are doing both. Since 2010, they started a very good cadaveric program, and they are doing a good number now of cadaveric in Japan. So I decided to compare both programs with our medium-sized program in King Faisal Specialist Hospital in Riyadh, which is a program doing about 35 cases a year. As we can see, this is from the International Society of Heart and Lung Transplant. Over the last few years, the number of lung transplants reached a plateau, about 4,500 lung transplants a year all over the world. This is our experience in King Faisal Specialist Hospital in Riyadh. The program started in 2010 by a small number of cases, 7 cases, 12 cases. And then over the last 4 years, nearly every year, we are doing around 35 cases a year. So, indications for lung transplant in the International Society of Heart and Lung Transplant, most of the cases are, a big part of the cases, 36% is COPD, followed by interstitial lung disease. In King Faisal, most of the patients are interstitial lung disease, and bronchiectasis is about 50% of the cases, either cystic fibrosis bronchiectasis or non-cystic fibrosis bronchiectasis. And COPD is a minimal, which is about 4%. Indication for lung transplant in Kyoto, in Japan. Most of the cases are interstitial lung disease or lung injury post bone marrow transplantation and idiopathic pulmonary hypertension. So as a surgeon, I'm interested, of course, to present some surgical details, and I think it's also very interesting to the pulmonologist to know what we are doing inside in the OR. So I'll go rapidly through the technique of lung transplant in cadaveric and in living donor lung transplant. So to start with, we open in the cadaveric recipient, we open the recipient clamshell incision, bilateral anterior thoracotomy, and transverse sternotomy. And finally, this is the view. In this case, you can see here the left pneumonectomy was already done, and the patient was put on central ECMO, and then we will put the lung to be implanted. This is the hilum. This is the bronchus and the artery and the left atrium ready for implantation. We start with the bronchus because it's the most posterior structure, and followed by the pulmonary artery to pulmonary artery, and finally left atrium to left atrium. And this is the final result. Both lungs are implanted and the ECMO or the cardiopulmonary bypass is weaned. Living donor lung transplant, Dr. Ahmed mentioned, we do a lower lobectomy, right lower lobectomy for one donor, left lower lobectomy for the other donor, and implant both lobes to the recipient. The donor lobectomy is the most important thing, I think, in this surgery. Safe donor lobectomy is the mainstay of living donor lung transplant. So we start by dissecting the hilum and clamping the artery, cutting the fissures. Then we go to clamp the inferior pulmonary vein, but we clamp the left atrium so that we can have enough tissue to suture for the donor and enough tissue to close the left atrium in the recipient. So we open the pericardium for that. After cutting the artery and the vein, we have the bronchus in the posterior, and we cut the bronchus tangentially to have enough length for the donor and to have also enough length for manual closure of the bronchus. And right lower lobectomy is the same. So the recipient operation, actually in the living donor lung transplant, it's nearly the same. Instead of whole lung, we put one lobe, but finally it's the same. Bronchus to bronchus, artery to artery, and at that time it will be left atrium to one vein. And again, while in cadaveric lung transplant, we don't put all the patients on cardiopulmonary support, only about it differs between the centers. For example, in Montreal, in Canada, where I was working last year, we do only 10 to 15% of our recipients on ECMO or bypass, while in King Faisal, we do about 75% on central ECMO. In Japan, in their living donor, they put 100% of the patient on central ECMO during the operation, because we are putting only two lobes, so you cannot... The single lobe, which will be transplanted first, cannot tolerate having the whole blood flow of the patient going to only a single lobe. It will go to edema, and it will be having bad results, and post-perfusion pulmonary edema will happen. So it's the same. Again, the hilum is here, and then bronchus to bronchus, artery to artery, and vein to left atrium. So to go on and to compare the results between the living donor and cadaveric donor lung transplant, I'll take some key papers from Kyoto, from the team of Professor Hiroshi Date, and our results in King Faisal Hospital, and also their results from the cadaveric lung transplant. So the first paper was the survival benefit in between the cadaveric and living donor lung transplant for their patients. So here, from 2008, and 2014, they had done 42 living donor lung transplant and 37 cadaveric lung transplant. 1 and 3 year survival were similar between the two groups. And it's actually amazing survival, 90% for 1 year and 88% for 3 years. So they concluded that living donor lung transplant, while their recipients were having worse preoperative condition, but finally the survival is equal to cadaveric lung transplantation. As we can see here, they used the ECMO support in the post-operative period. This is very important. Utilization of ECMO support in the post-operative period means that the patient after the lung transplant had primary graft dysfunction or reperfusion pulmonary edema grade 3, and he needs an ECMO support. So as we can see here, it was in the living donor 6 patients, which was 14%, and in the cadaveric 7 patients, and that was 19%. And this is the actuarial survival in between the living donor in red and the cadaveric in blue. And as we can see, it's nearly the same. This was a very nice article also by Professor Date in 2017, a review article about living donor lung transplant. And here we have the comparison between the pros and cons between living donor and cadaveric lung transplant. So the waiting time for the living donor lung transplant is of course shorter. The mean time to wait for a cadaveric lung transplant in Kyoto is about 2 years. In King Faisal is about 1.5 years. Not all the patients can tolerate waiting all that time, but finally the living donor lung transplant is shorter waiting time. The schedule is controllable in the living donor lung transplant, while most of the cadaveric lung transplant will occur at midnight. Ischemia time is shorter in living donor lung transplant, and that affects the results. The graft size is smaller in living donor lung transplant, and you give the patient the whole lung in cadaveric lung transplant. So this is an advantage to cadaveric lung transplant, but in the living donor, you give them a small but perfect graft. Primary graft dysfunction is infrequent in living donor lung transplant, while it's 10 to 20% in cadaveric. And the infection is more frequent, of course, in cadaveric lung transplant because the donor is on the ventilator for a long time. The number of team, it's more complicated in living donor lung transplant. 3 to 4 teams are needed, while in cadaveric lung transplant, it's only 2 teams are needed. Bronchial complications is more in cadaveric lung transplant, and chronic rejection. This is a very important point. It's a major cause of death in cadaveric lung transplant, and it happens in 50% of the patients within 7 years. While in living donor lung transplant, even if the patient will have chronic rejection, it's less because it's usually a living-related lung transplant, or always even living-related lung transplant. And if one of the lungs had the chronic rejection, the patient can continue depending on the other lung, which is not having the chronic rejection. And this is a very, very big advantage for the living donor lung transplant. But of course, the main issue with the living donor lung transplant that we are exposing 2 healthy donors for allobectomy. The outcomes of living donor, this is very important because we need a safe lobectomy for these donors. 20% of the patients from Kyoto University of the donors had some complications. Most of them are trivial complications, meaning some pneumothorax or some pleural effusion needing drainage. But 5% of these patients, they needed surgical re-exploration or bronchoscopic intervention for bronchopleural fistula or for bleeding or things else. But finally, it's 5%. 3 technical differences between the living donor lobectomy and the usual standard lobectomy which we do. First, that the pericardiectomy around the inferior pulmonary vein can cause some arrhythmia. Second, that the division of the right or left lower lobe bronchus in a tangential way can cause some problem in the healing or stenosis or bronchopleural fistula, and administration of 5,000 to 10,000 of heparin in the donor before clamping also might stimulate bleeding. So this is a prospective study analyzing 1 year outcome in the living donor lung transplant from Kyoto University. The donor selection is very important. So the donors are living related donors, so relatives from the third degree or a spouse, age between 20 and 60, ABO identical or compatible, and the others, I will not go through them one by one, but the donor selection is very important, and he should be a healthy donor and mentally and physically healthy, and he should take the decision to donate without any pressure. This is very important. So the early and late post-operative complications, these were 65 donors, in which 17 had early complication, which is 20%. Most of them, as I mentioned before, were pneumothorax or pleural effusion.
دكتور محمد معلش بنفكر حضرتك بس بالوقت، وطبعا الوقت الموضوع كبير.
Just 3 more minutes.
عايز ساعات، اتفضل.
So extracorporeal pulmonary support was required. This is another paper in the outcome of living donor lobar and cadaveric in patients with pulmonary hypertension from Kyoto. They used the extracorporeal circulation in 5 living donor and 4 cadaveric, 5 living donor of 6 and 4 of 10 in the post-operative period, meaning that the primary graft dysfunction was more in living donor lung transplantation. But finally, the 1 and 3 year survival was excellent. I'll go directly to the, this is the experience of King Faisal outcome of marginal donors in lung transplant. 180 cases of lung transplant were performed, 92% marginal cadaveric donors, where the results, the survival, we will discuss it here. 1 year survival was 87%, 3 year survival 76%, and 5 year survival 62%. So here, this is the table comparing the living donor lung transplant in Kyoto with the cadaveric donor lung transplant in Kyoto and the cadaveric donor lung transplant in King Faisal Hospital and International Society of Heart and Lung Transplant results. So the mechanical ventilation is longer in living donor lung transplant. Intraoperative ECMO is 100% in living donor lung transplant in comparison to 30 in Kyoto and 77% in King Faisal Hospital. The forced vital capacity and FEV1 in the first and third year are equal in different techniques. 30 days survival and 1 year survival and 3 years survival and 5 year survival are equal between the living donor and the cadaveric donor lung transplant. And post-op ECMO, meaning that severe or grade 3 primary graft dysfunction are also equal, except here in Riyadh, of course, it was much more, 24% due to the utilization of marginal donors. So in conclusion, successful living donor lung transplant largely depend on safe donor outcome. It's clear that the living donor group in Japanese experience were more complicated case. However, they had similar survival as cadaveric donor. The living donor recipients who receive significantly undersized lobar grafts, they receive only 2 lobes instead of 5 lobes, but however, they have good survival, and living donor lung transplant should be performed under appropriate circumstances, considering the inherent risk to living donor. Finally, the conclusion that living donor lung transplant is a viable option for patients too ill to survive a long waiting period for cadaveric donors, or if there is no available cadaveric donor program as the case in Egypt. But I hope we will soon have this cadaveric donor program. But till we have this program, which might happen in 1 or 2 years, we need to start our program of living donor lung transplant. And thanks.
Thank you, Dr. Muhammad, for this nice presentation. I would like here to welcome Professor Dr. Hiroshi Datei, the head of the Thoracic Surgery Department, Kyoto University Hospitals, and the pioneer living donor lung transplant surgeon.
Can you hear me?
Yes, yes, we can hear you.
Okay, great. Thank you very much for kind invitation. It was very nice to meet Dr. Mostafa on the web, and I hope you and your colleagues had a great time in Kyoto. So I'm gonna share my experience on lung transplantation in this lecture, and I found that most of the my talk have already been covered by you and your colleagues. So I'm trying not to spend too much time in the same issue. I have nothing to disclose in this presentation. So I started lung transplantation in Japan first time in 1998. So over the last 20 years, lung transplant activity has expanded significantly. In 2010, we changed a law and the number of cadaveric lung transplantation has increased dramatically. At the same time, waiting list for cadaveric lung transplantation has expanded, and the number of actual cadaveric lung transplantation have been limited. As a result, the average waiting time exceeded 800 days, and almost half of the patients on the waiting list have died. Therefore, the need for living donor lobar lung transplantation does exist in Japan. This is the inclusion criteria for living donor lobar lung transplant recipient. We accept only critically ill patients. Inclusion criteria for living donor has been already presented. We accept only relatives. And it is important how to inform this operation to the potential donors. So we inform them about the permanent loss of vital capacity, possible various complications, possible mortality. To avoid coercion, we ask an observer to be present. We do an individual interview so that the potential donors can express their thoughts honestly. We repeat the interview at least 3 times so that to give them what is called a cooling off period. I have done more than 300 lung transplants in Japan, which is about 1/3 of the lung transplant in whole experience in Japan. Half of them were from living donors. Pre-operative condition of these patients were very poor. 60% of them were bed-bound and 12% on a ventilator. Size matching is very important because only 2 lobes are implanted. There are 2 ways to analyze size matching. One is a functional size matching, which is depending on the measured donor's FVC and estimated FVC of the recipient. The another is anatomical size matching based on CT volumetry of the donor and recipient. If the lobes are too small, this kind of disaster could occur. If the lobe is too large, this young boy had a funnel chest and received a right single lobe transplant from his mother. The lobe was too big, the chest could not be closed, and we lost this boy due to sepsis. So we have developed 2 strategies for undersized graft. One is upper lobe preserving transplant, which we have done only on 14 patients. For example, this recipient was a 21-year-old male with pulmonary arterial hypertension. A functional size graft was 40%, which was less than 45%. So we preserved a upper lobes of this patient. Clamshell incision was made and aorta was cannulated. Right femoral vein was cannulated for drainage. The second drainage line was inserted to the superior vena cava via the right atrium. We use ECMO, and activated clotting time was maintained between 180 to 200 seconds. Right middle and lower lobectomy was performed. And then the trunks intermedius was opened. The right lower lobe from his father was placed in the chest cavity. Bronchial anastomosis was performed between the recipient's trunks intermedius and the lower lobe bronchus of the donor. This is a venous anastomosis between the donors and left recipient lower pulmonary vein. Final anastomosis was pulmonary artery. A vascular clamp was placed in the fissure, and the pulmonary artery was sewn by a 6-oproning running suture in an end-to-end fashion. The right lower lobe was re-perfused and re-ventilated. You can see the preserved right upper lobe as well. And then the attention was taken to the left side. The heart was retracted and the posterior pericardial stitch was placed near the pulmonary vein. And using the tourniquet, an episiotomy pack was fixed, and the heart was retracted toward the right shoulder of the recipient. This gives an excellent exposure, access to the left side. Left lower lobectomy was performed, and left lower lobe from his mother was implanted. You can see the preserved left upper lobe. Weaning from ECMO was not difficult. You can see a preserved upper lobes and implanted small grafts. On the right side, you can see a post-operative chest X-ray. A pulmonary artery pressure was normalized, and you cannot distinguish where the preserved upper lobes and implanted small grafts. Perfusion scan showed a majority of blood flow were directed to the small grafts implanted, indicating that a preserved upper lobes provided adequate chest cavity for the small lobes implanted. The another technique we have developed was right to left inverted living donor lobar lung transplantation. This was based on the fact that the right lower lobe is generally bigger than the left lower lobe. For example, this 24-year-old female suffering from bronchiolitis obliterans after bone marrow transplant for leukemia received the right lower lobe from her brother and left lower lobe from her mother. And the left side is the graft inverted and implanted, very nicely expanded in the left chest cavity. Regarding the oversized graft, which often happens in a pediatric recipient, a single lobe transplantation was often performed. And occasionally we did a simultaneous pneumonectomy for the extreme oversized graft to make more room for the graft. The right side is the post-operative X-ray after right single lobe transplantation with a simultaneous left pneumonectomy. The heart was sitting on the left chest cavity. After this operation, the recipient is still alive, 12 years. She is now 12 years now. Downsizing by segmentectomy could be performed. The right side is a basal segmental implantation. Last month, we did a very complicated operation for a 4-year-old boy. He received the right basal segment for the right graft. And for the left side, his father donated a superior segment of the right lower lobe, which was inverted and implanted as the left graft. This is how it looks like now. He is recovering nicely now. We often use a delayed chest closure technique, which has already presented. We just close the skin and rib cage is left open, and rib cage is closed in a couple of days. These are the indication of my experience. Interstitial pneumonia, bronchiolitis obliterans, and pulmonary hypertension were the 3 major indications. We have accepted various indications for living donor lobar lung transplantation. Most of the patients suffering from bronchiolitis obliterans had a history of bone marrow transplantation for leukemia. This is the long-term survival result in my experience in 147 living donor lobar lung transplantation. The 5-year survival rate was 83%, 10 years 75%, and 15 years 67%, which was much better than the world average. Not only the survival, but also the quality of life was excellent. Pediatric patients, kids return to their school lives, and they can attend the sports festival. Regarding the living donors, we did have some complications, but they all recovered and no operation-related death occurred. However, you can see that function never recovered to the baseline. Again, this is my experience, and I would like to emphasize that the outcome could differ among transplant centers. This is the result from other institutions in Japan, and this is the result of University of Southern California, which pioneered this operation. This is Washington University Children's Hospital, where I was trained, and this is the report from Brazil. Finally, I would like to emphasize the importance of a team effort. I am very proud that in Kyoto University, we have a very good team, and that is the key to have good results in living donor lobar lung transplantation. Finally, I would like to thank again for the kind invitation for this opportunity. Thank you very much.
Any questions, please?
Thank you, for, Professor Date, for the excellent presentation and for the innovative technique and the excellent results. I have a question about the results and the significant better survival of living donor lung transplant when we made the comparison with the results of International Society of Heart and Lung Transplant. For example, the 10-year survival in your case was more than 75%, and in the International Society of Heart and Lung Transplant, it doesn't exceed 40%. Do you think this is because if it's a living-related lung transplant, so the risk of CLAD or the risk of CLAD, the chronic lung allocation dysfunction, is much lesser in living-related donors, or what do you think the cause? Because by logic, we are giving this patient 5 lobes and you are giving the patient only 2 lobes. So usually the survival, we might say that the cadaveric will be better, but it's significantly better in the living donor. Thank you.
Thank you very much. First, I would like to report on my experience on cadaveric lung transplantation, which I did not show you in this presentation. In my over 150 cadaveric lung transplantation experience, the 5-year survival rate was now about 75%, which was also much better than the world average. So the better outcome of survival is not only related to the source of donor, but I think the careful management and so on. The recipient of living donor is much sicker. If the outcome of cadaveric lung transplantation and living donor transplant are similar, as I presented already, the actual survival would be better in living donor lobar lung transplant if the recipient condition is exactly the same in the beginning. Why better in living? And that is probably immunological phenomena. First, it comes from relatives, blood-related relatives most of the time. And second, we transplant 2 lobes into 2 lobes from 2 different individuals into 1 recipient. So as was presented in the last speaker, even when the one lung is rejected, the other non-rejected lung can support the life of the recipient. Thank you.
Can I just one last question, please?
Sure.
Have you done any lung transplants for COVID patients complicated with the pulmonary fibrosis, and any special precautions have you taken And how did you manage to go on with the lung transplant program during this critical period? Thank you.
Your question is lung fibrosis caused by COVID-19? I couldn't hear you well.
Yes, yes.
Okay.
Yes.
No, we have not done any, but we had one consult and about to perform living donor lobar lung transplant, but found that the recipient had other organ failure, so I didn't do it. I think in a particular patient who recovered a virus infection and but the lung is irreversibly damaged, maybe the candidate for urgent lung transplantation, which has already been done, some in China, USA, and Vienna in Australia.
Just one last small technical question. I saw you are cannulating bicaval in the ECMO. When we usually do the lobar transplant for small patients, lobar cadaveric transplants, we put just a double stage cannula in the right atrium. Do you think that makes any difference, or why you are doing the bicaval cannulation?
Thank you very much. I think a single double stage drainage can also work. When we do a right pulmonary artery anastomosis, sometimes you have to pull the superior vena cava medially, tightly. That often causes a central venous pressure up, and also the decreased Ricaldica output. So if we have another drainage line into the superior vena cava, you can retract this drainage line itself without causing any CVP dropping, CVP increase. That makes a much safer right side small lung implantation. That is the reason why we like to have two drainage lines.
Thank you very much. From the audience here, we have a question. Does the LA better matching between the living donor in comparison to the cadaveric donor play a role in the long-term survival or not?
You mean the left atrium?
No, the HLA.
HLA matching.
Yes.
Yes. I think the definitely HLA matching is better in living donor lobar lung transplantation as compared to cadaveric lung transplantation. Yes. But I am not sure HLA, the number of HLA matching itself is the reason why the better outcome comes from living donor lobar lung transplantation, because there are a number of other factors could be involved, such as a short ischemic time, size difference, and so on. So it's very difficult to distinguish whether the difference of outcome comes from HLA matching, mismatching, or other factors. But I believe that the similarity of HLA matching is a significant benefit in living donor lobar lung transplantation.
Thank you very much for your participation. Unfortunately, we have to move on, and we hope to see you soon in Cairo. Thank you very much, Professor Dati. Thank you.
Thank you. Dr. Mustafa, you should have told me that you couldn't find a good cheese. Next time, I will show you where you can find it, okay?
Thank you very much.
Okay, thank you very much.
All right. See you soon. Bye.
Thank you, my dear professors and colleagues, for this very nice session. The second session will be Sandoz Symposium. I would like to invite Professor Dr. Yasser Mustafa, Dr. Assam Gouda, and Dr. Ashraf Mukhtar for the